Hello, my name is Arya Javidan. I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to today's webinar, Value-Based Care Integration Using RPM Data to Succeed in Alternative Payment Models. Today's webinar is hosted by the South Central Telehealth Resource Center, and these sessions are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. The consortium is collecting success stories from organizations, patients, and providers who have benefited from telehealth with the support from a telehealth resource center. Share how your telehealth resource center helped make telehealth work for you for a chance to be featured along with your organization in our consortium newsletter, and we've included the QR code and the link there. And just a few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using the chat to ask questions or make comments. Please also note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the Consortium YouTube channel and the Consortium website at telehealthresourcecenter.org. With that, I will pass it over to Joe Schaffner, Program Director for the South Central Telehealth Resource Center.
Thanks, Aria. Hey, everyone. I just have a few slides before I turn it over to our guest speaker today. So there's me. I'm the moderator. Same map that Aria shared, but I also just wanted to point out that we are located in red. We represent Arkansas, Tennessee, and Mississippi. So if you have any questions about the region, if you're coming through the region, also want to point out that we have telehealth training centers. You can physically touch the equipment. We can have discussions about what would best suit your needs or what you're trying to do. And also, this is our contact info, our email, info@learntelehealth.org. Also want to direct you to our website, learntelehealth.org. Wealth of resources, abundant library. So go check that out. And now I'd like to introduce our speaker. Jason Goldwater is currently the President and Chief Operating Officer for Laurel Health Advisors, where he oversees business development operations and client delivery activities. Mr. Goldwater has been in the field of health information technology, quality management, rural health, and health services for 27 years, and has led a number of projects on research and evaluation of health IT on access to care, electronic clinical quality measurement development, and implementation, Medicaid payment, and healthcare reform. Mr. Goldwater has written and spoken extensively in the areas of telehealth, blockchain, quality measurement, and digital health, and how it can impact populations such as the homeless and the chronically ill. Jason, I'll turn it over to you, man.
Thanks so much, Joe. I greatly appreciate that. And good afternoon, friends. Always very nice to be here speaking with you all today. Many thanks to Joe and Aria for allowing me this opportunity. And great thanks to my dear friends at the University of Mississippi Medical Center for allowing me to present this in substitution of Dr. Chandra, which I always enjoy doing. So I'm here today really to give a talk about integrating RPM data into alternative payment models, really to show sort of the correlation between the use of these digital technologies and how they can effectively be used in a number of value-based care models. As many of you may have noticed, CMS has released a number of these just this year and plans on releasing several more before the end of the fiscal year, so before the end of September. And almost all of them have a technology component to that. So it really sort of provides an environment in which leveraging these technologies will be very helpful in allowing states that receive the funding for whatever model they may be looking to get into to really help be successful and meet these metrics. There is a real push by this current CMS administration to really focus on leveraging these technologies as much as possible, and really understanding how they can be used in a way to improve population health and also to help lower the cost of healthcare. Next slide. So there has been over the last many years, since really the passage of the Affordable Care Act, a shift to value-based care. So we really are moving from volume into value. So not really necessarily looking at trying to gather the most patients possible in a particular day and billing for those patients. It's really to be able to provide value. And we really sort of describe value as providing enough of an intervention for a patient that there's little possibility that they may be relapsing, may have to go to the emergency department for an unnecessary visit, or may require additional measures to be taken that might always be sufficient or really even needed. It's to provide value that at the point of that first initial encounter, that enough information is given to the provider who can then take that information and leverage it into a way that they're able to provide comprehensive care and a comprehensive care plan for that patient that will not that will remove them from seeking unnecessary care, which, as you all know, is a major driver. So we've moved from fee for service into value-based care, and the real trends over time have been the growth of a lot of accountable care organizations, the expansion of these bundled payment models. CMS has really made a significant focus on quality and metrics, and having been in quality measurement since the early 2000s, really showing my age here. We moved into starting with abstracting measures off of medical claims. Then we moved into electronic measures off of EHRs, and now CMS is really pushing the use of digital quality measures, which are the ability to use a lot of these technologies and understanding how they are affecting the overall quality, not just of an individual patient, but also about population health. So the success of really ensuring success, I should say, about your participation in value-based care really requires continuous patient insight. The more you know about a patient, the more you know about their condition or conditions, the more information that you have and data that you can use, you can be far more proactive in their care plan. So the more data that is available, the more proactive you can be. Next slide. So what is the role of remote patient monitoring with respect to value-based care? So it's continuous patient data outside the clinic. So rather than waiting, as you all know, for a patient to be inside of a clinic or some sort of facility and collecting data there, the ability to leverage these technologies provides data before they even step foot inside of a clinic. So a lot of these RPM data sources include things such as blood pressure monitors, glucose monitors like continuous glucose monitoring, pulse oximeters, weight scales, wearable devices, and digital symptom tracking. Having this sort of continuous patient visibility and knowing at any given point in time sort of what the patient's status is enables much earlier intervention and then much more proactive care. And as we just said, you succeed in value-based care when you are proactive, when you're able to create an intervention and a care plan for a patient that mitigates or reduces the use of unnecessary care, for they're not going into emergency rooms or seeking other types of treatment or unnecessary lab tests, or even to some extent unnecessary medications, all of which combined together really drive up the cost. So if we're leveraging this data in a proactive way and really understanding a patient's condition and being able to structure that and then get verification and validation once they are actually in a provider setting, then that really helps you succeed overall in any sort of value-based care model, particularly the ones that are coming out now. Next slide. So why does RPM matter for value-based care? So this is really an issue that has been sort of top of mind with CMS and really HHS overall for the better part of the last couple of years, really under this premise that if you have continuous data, it drives better outcomes, it lowers costs, and it provides a lot of smarter care. And that's largely because value-based care requires providers to prevent complications, manage chronic disease effectively, reduce avoidable utilization, like again, not seeking emergency care when it's not necessary, and then demonstrating measurable quality improvement so that they are able to control their blood pressure and their hypertension, that if they are diabetic, that their A1C is under 7.0, which is sort of the common standard for people who are managing or controlling their diabetes, that they're adhering to medication, that they're going for the checkups that they need to, that they are, if they have COPD, they're not only taking their medications, but they're doing, breath tests or breathing tests rather, on a regular basis. So to monitor the airflow, these are things that, the technologies exist now where they can do that, and the data immediately goes to the provider. And when you have that RPM effectively implemented, you can detect risk earlier. So you really know if a patient's diabetes is not controlled, if their glucose readings are sort of off the charts, if their hypertension is elevated, you can detect that risk and create a proactive intervention rather than waiting till the patient gets to a crisis point and then being able to then take on an intervention. You're able to be much more proactive about it. You can improve patient engagement because that data sharing provides a dialogue between the patient and the provider. It generates measurable performance data because, again, the technology itself does keep a log of what data it's collecting and when that data is being sent, and it supports overall long-term care improvements. And so the overall objective is really to have better outcomes, lower costs, higher patient satisfaction, and much stronger quality metrics. Next slide. So key value-based primary models, or payment models rather, you're managing financial risk. That was the whole point of designing these types of models and bundled payments, which was to effectively manage risk. So that way, again, you're being much more proactive and engaging earlier rather than waiting to the point in which much more serious interventions may have to take place that could have been avoided had that earlier intervention been had taken place with the data being received. So accountable care organizations, they're about population health management and shared savings amongst providers. Bundled payments are really about episode-based care management. And then RPM also enables these value programs under Medicare Advantage and also commercial value-based contracts. It really does provide this overall data infrastructure necessary to manage financial risk, which really ties in to what the overall value proposition is for these alternate payment models. Next slide. So the first thing that we really point out when we talk about RPM and value-based care is that the technologies that exist now that are really utilized much more commonly than they were, say, 5 or 6 years ago, is that the use of them really helps identify high-risk patients earlier. So you can see with a lot of these technologies, when hypertension is rising and they're at a serious, stage 2 level or higher, in which may, based on the condition of the patient or factors regarding the patient, such as their age or previous health history, may lead to a serious situation. Worsening glucose control. If their glucose control is really, really high, and their A1C then is over 7%, and these are uncontrolled diabetes, the significant health effects that could occur around somebody like that. Not just high blood pressure, but real damage to the liver, damage to the kidneys. And so that risk then, if it's not taken care of, may have significant consequences for the patient, and then overall really defeats the purpose of why you would have value-based care. So you want to be able to manage risk in a way that you're providing value to the patients and recouping these savings. Other things that RPM can do is rapid weight gain. indicating heart failure exacerbation, and then declining oxygen saturation, particularly people with chronic breathing conditions like asthma or COPD. So if you have early detection, it not just allows for medication adjustments, but it can also immediately lead to a telehealth consultation and preventative steps that need to be taken before this exacerbates into a situation in which the patient's not just health, but life could potentially be compromised. But in terms of a value-based care contract, again, it's defeating that purpose. It's not something that is suddenly becoming managing risk. You've allowed that risk to take place, and as a result, you're not engaging in sort of the overall savings that you want these value-based care models to generate. Next slide. So RPM really also allows not just medication adjustments and telehealth consultations, but you can just see from this graphic that it really has shown, and there's a lot of evidence about this. I'm sure all of you know this. A lot has been written about it, about if you really effectively use remote patient monitoring and focus on a cohort of patients with particular conditions in which those devices would be particularly useful, it has shown that it reduces unnecessary ER visits. And the single biggest driver of healthcare costs is individuals going to the ER when they don't need to. And that's why there's so many measures, quality measures around that. That's why, NCQA, the Joint Commission, and at one point in time, the National Quality Forum really developed a whole suite of measures around 30-day readmissions, really making sure that if you are engaging with the patient and developing an intervention and a care coordination strategy, it's designed to be able to keep them from coming back to the ER. Because if they keep coming back, not only is their health worsening, but it's also causing the cost of healthcare to continue to drive up. And the point of value-based care models is try to bring the costs down. So, apart from, I think, developing sort of proactive engagements, it's also really necessary to be leveraging RPM because it keeps people out of the emergency room. And I think when we're trying to make cases about integrating technologies into certain alternate payment models, that really needs to be one of the key arguments. It's allowed, not just allows you to be proactive and create, better interventions at the point, prior to a patient encounter, but it also really keeps people out of the ER. And apart, I think, from, like I said, the financial impact, if a patient is continually going to the ER, then their health isn't getting any better. Their health is just getting worse because something is not being done or some things are not being done that would effectively provide that necessary care. Next slide. So, how does RPM really focus on chronic disease management? And I think, as you all know, chronic disease management, again, is a high cost driver and really one of the reasons why value-based care models were created, because most of the time, I think, as you know, people don't just present with one chronic condition. They usually have several chronic conditions. They're multimorbid. And when you have that, there has to be a really significant strategy about what lifestyle changes you're going to need, what medications you're going to need, what types of visits you're going to have to be making. And then depending upon the age and disposition and sort of where the patient resides, really is going to determine about how that's going to be developed and implemented. And especially in areas in rural America, where being able to see a provider on a consistent basis in person is at times very, very difficult to do. This is really where RPM has shown its success. And at UMMC, they really have done a number of studies to really underscore just how powerful this can be. Having RPM really does support the control of these conditions, things like hypertension, diabetes, heart failure, COPD, and even postoperative recovery. And when you use this effectively, it improves clinical stability. There's a lot of studies, and I really thank my colleague Carly Brown Dr. Carly Brown, I should say, from Mississippi, who has really led a lot of this work and has not just shown the improvement in stability, but also, I think even more important, has shown improved medication adherence. That's sort of one of the biggest things that occur with patients when they are not in consistent dialogue or data is not being exchanged between themselves and their provider is that they're not always adhering to their medication protocol, particularly if they have multiple conditions and their disposition and health history and potentially their age may lead them to have to take a number of medications for the conditions that they have. And so RPM also really has shown much better patient self-management because it's not just only communicating between the patient and the provider, but many of these devices really do have dashboards or front ends that really show not just what the patient needs to do, but what the status of the patient is in a way that they are able to interpret and understand and send that data to their provider in order for an intervention to take place if it is necessary, or for adjustments to a care plan to occur, or if another dialogue needs to be created between their care team because of particular aspects of their treatment plan that need to be adhered to that may not be necessarily as effective as perhaps they were initially thought to be. Next slide. So one of the things that I've always noticed, and I have spoken about this and written about it, is the use of telehealth just in general, but particularly these digital devices really helps improve quality measure performance. Because these value-based care contracts depend heavily on these quality metrics being met. And a lot of these are very, very standardized and have been around for a very long time. But you look at things like blood pressure control, management of diabetes, management of heart failure, readmission rates, like I said, is the biggest driver, and there's a major whole suite of measures around that. And then, some other ones that have come around that have really taken shape over the last decade and have really focused a lot on preventative care. Because again, as the value-based care model started to rise, the need to develop measures around preventative care so that they were in alignment with the objectives of the model were viewed as very necessary. So, how then are you able to really effectively measure quality and outcomes with the patient? Because a lot of measures over time were measuring process. So, you give somebody aspirin after a heart, on the onset of a heart attack, or you provide, certain strategies if they have shown to have uncontrolled diabetes. But when you have continuous data, because I should go back and say quality measurement used to be very much a static type of science, which is it was a snapshot in time. You would have a patient, that patient would be taken care of, and then the quality measure would be at what happened during that encounter. And then you could not reevaluate that quality measure until the patient came back for another visit. And that was fine for a while, particularly when we were taking measures from medical charts or even in just the beginning stages of electronic measurement. But with the technology and the devices we have, it goes from being static to evolving. So a patient's continuous changes in quality are going to occur, and you are able to monitor that in a value-based contract using these devices because the data is not just flowing during an encounter, the data is flowing rather regularly. So continuous data allows for far better documentation of the clinical improvement in the areas that align to those incentives in value-based care contracts. But beyond that, meet what that overall objective and goal of a value-based contract is to begin with, which is to be proactive in care, keep high cost drivers away or mitigate them completely, and then most importantly, providing comprehensive care to the patient with consistent dialogue, basically really creating strategies that provide care to patients on a regular basis that meet or exceed at times what these quality measures are. Next slide. So another good one, I mean, the other, aspect of value-based care was if you are putting somebody in a value-based situation, a situation where they're in one of these models, apart from really trying to drive better outcomes, you're also really trying to drive better care coordination. You have basically the primary care physician at the center or the nurse practitioner or the PA, but then they're coordinating care with those other providers that are necessary in order to provide the best comprehensive interventions for this particular patient. And that's why value-based care really requires proof of these care management activities, patient engagement, and particularly coordination across providers. RPM supports all of this. It supports documentation of these alerts and interventions, the care team outreach, the patient communication, and the monitoring compliance. And those overall activities really strengthen the quality reporting and the payer accountability. Next slide. So what I think really becomes exciting, at least for me, about the evolution of so many of these technologies, and there's so many of them now, which is great. It's not a bad thing. It's not about just blood pressure or diabetes control. I mean, they have technologies now to really assess risk of diabetic neuropathy. They've got remote EKGs to really monitor heart conditions for people that have either had congestive heart failure or at greater risk for having it. But I think where this really becomes exciting as somebody that's been in public health for so long, that the RPM data doesn't just become valuable when it is dealing with a patient, but when you integrate this into a population health tool, you really can sort of see much more detail and much more information on the population as a whole, that you're able to create effective strategies around these populations independent of an individual provider intervention. So you can build these tools into electronic health records, population health dashboards, risk stratification systems, or care management platforms, which enables data-driven clinical decision making. So one of our clients, which is the New York City Department of Health, recently, I should say, just had us do a return on investment analysis for their diabetes self-management program, which they are leveraging these tools. They didn't want to just see the ROI on an individual patient basis. They wanted to see the ROI from a population perspective, because there are lots of cohorts within their Medicaid population that suffer from type 1, type 2 diabetes more prevalently, and need to have strong self-management. And what we saw in that analysis was, when you're leveraging things like continuous glucose monitors, food diaries, um, weight trackers, and having that information sent to a nurse case manager on a regular basis, that what they saw is outcomes improve by almost 72, 73%. And overall, they were making, the multiplier for ROI was well over eight, or basically 800%. So essentially, for every dollar that they're putting into self-management programs, they're getting $8 back in a return. And that's from avoidable complications, not going to the emergency room, being able to manage their diabetes and subsequently manage whatever conditions are coming from that. It is really significant, a significant return, which shows, I think, the real power of what RPM can do, not just from an individual patient perspective, but also from a population health one as well. Next slide. So I would really then encourage that one of the things for us as a community to really talk and push forward in is how we build this RPM data into these dashboards, because it really becomes valuable in a way that I don't think a lot of people have really seen just yet. Those dashboard capabilities can be risk segmentation, alert prioritization, which is what New York City did, trend analysis, and outcome monitoring, also what New York City did. Effective dashboards really combine the RPM data with claims data, clinical records, in particular, social determinants of health. Creating an equity overlay over this RPM data really shows, I think, what factors may be causing a deterioration of health independent of what an RPM device could do. So, yes, a patient may be able to weigh themselves and send that data to a provider, but if they're in a situation where healthy food is not anywhere near them, if they have limited transportation and unstable housing, that requires interventions beyond just clinical. And if you integrate RPM data, you could see what they're doing from a clinical perspective, but then you have a better understanding of what those social or health related social needs are to create overall interventions on the individual level and on the population level as well. And then understanding things like utilization patterns as well. Next slide. And so this is sort of my son used his graphic capabilities, which I did not know he had until he came up with this, but what a dashboard like this might look like, and really understanding vital signs, the demographic areas, aligning what the risk may be, utilization amongst the cohort patients, and so forth. But these kind of dashboards, I think, are what we're really going to start seeing in value-based care models, apart from sort of, again, the individual intervention, the population health interventions as well. Next slide. So I think overall, again, it's really using RPM insights to help drive better care management. You know, RPM data should really trigger targeted care management interventions, you know, with nurse outreach when thresholds are exceeded, understanding when you need to titrate medication based on specific protocols, based on a patient's condition. And again, that idea that it really helps with medication adherence shows you much more about when you need to do that titration. It will immediately show, we would hope, when there needs to be a telehealth visit, not just a data exchange, but an virtual visit, when they need to be referred to specialty care and behavioral coaching, which is now becoming incredibly popular. There's a number of apps and digital tools to help with behavioral coaching, and a lot of major health payers are picking up on those tools and providing them to patients as a way, again, of showing data that can go to their provider that will eventually be sent to the plan, but also allowing for much more direct coaching in things like weight loss or better dietary habits, better food management, or even education as a whole. Next slide. So in order to make that successful, you really have to align RPM with care management workflows. And this is something you have to do in any time you're integrating any sort of technology. RPM always works best when it's integrated into these workflows, automated alert generations, clinical triage protocols, outreach to the care manager, escalating to a provider if the situation gets to a point where that level of intervention is needed, and then documenting why, what intervention took place, why, what the result of that was, again, measuring against evolving quality measures with evolving data. But when you integrate that into the workflow, it becomes much easier for providers to be able to understand their patients. But it also ensures that RPM improves care rather than just creating alert fatigue. So you don't, you know, that's always also been a problem when it comes to things like clinical decision support. When there's constant alerts that are going on for a provider to take note of, eventually that alert fatigue can get to the point where they turn off the alert feature, which then defeats the purpose of clinical decision support. But when you integrate RPM specifically, which is alert me if their protocol, you know, if their A1C gets to this point, or their blood pressure is here, or they're not taking medication here, or their medication is showing to not be effective, you know, that's when there's the outreach from the care manager, escalating to a provider when necessary, developing an appropriate intervention, and documenting that. Next slide. So I think we're already getting to the point now, you know, the time that I first gave this, which was a while ago, you know, I think we were sort of on the threshold of really demonstrating value to payer partners, but a lot of these payers are now, I think, fully understanding that. And, you know, credit to CMS for really making this sort of the cornerstone of these new models that are coming out. You know, payers want evidence of cost reduction, improved outcomes, and better chronic disease control. But RPM really does provide those measurable metrics like reduced admissions, reduced ED visits, improve quality scores, and improve medication adherence. The workflow integration ensures RPM improves care rather than creating, again, an unnecessary amount of alerts or information that would not necessarily be usable. Next slide. So healthcare organizations can use RPM data really to support value-based contract performance reports. They can show the demonstration of clinical improvements. They can provide better population health insights, which will allow for much more strategic and focused and targeted public health interventions, and document what those activities are. And so that transparency builds much stronger payer-provider partnerships. Next slide. So you can also structure these shared saving models with RPM. You can incorporate RPM into value-based contracts through shared savings, tying them to utilization reduction, quality bonuses, which happens when you are linked to these metrics. You're either meeting or exceeding what those metrics are, payments for care management, or then doing appropriate risk adjustment for patient monitoring programs. RPM really does serve as the basis for a clinical tool, but you can use the data within these devices for a better financial strategy. And again, because you're continuously monitoring against these clinical quality measures, inevitably, or hopefully inevitably, they lead to much better outcomes. Next slide. So there are some operational considerations, obviously. I mean, it would not be, I wish it were so easy as we just, get our RPM devices and they're already hooked up, and we can automatically start communicating with providers, and there's automatically this coordination between the patient and the provider. But that obviously is not true. There's both a technology infrastructure and an operational one. You have to integrate the device into not just the workflow, but the technological infrastructure of whatever provider community is going to be using this. There has to be EHR connectivity between their system and the remote patient monitoring device. That data does need to go into their chart so that it can be reviewed later and followed. And then really data analytics platforms. That becomes not just important from the patient perspective and reporting out to CMS, but from a population one as well. Operationally, you need the right care management staff that will be able to interpret the data, be able to report that data to the appropriate providers, be able to coordinate care as necessary and determine what interventions are needed, and to make sure that both the provider and the patient are meeting or constantly communicating to ensure that avoidable interventions are not taking place. To make sure that the right clinical protocols are being followed, and then data governance, which is a big one. You don't want that data to be going outside of any sort of boundaries that are not allowable, and really focusing on the data that can be used, particularly for improving quality of care and improving patient outcomes. Next slide. So future directions. I feel like everybody talks about this now. So I feel I have to talk about it, which is AI and predictive analytics. I'm sure all of you know, if you wake up in the morning, I'm sure out of 10 emails you receive, 7 of them probably have something about AI in them. It's like everybody and their mother is talking about this. And sure enough, the next generation of RPM is absolutely going to include AI-driven risk prediction. And from that, we'll build predictive hospitalization models. So they'll show, based on the data that they have and what they're taught, what's the risk of an individual moving into a situation that would be avoidable otherwise. And when would they need to be hospitalized? What kind of strategies need to be implemented, and so forth. And there would be these automated care pathway recommendations as a result of the data that they're receiving. I do want to note that even as we automate all of this, it doesn't mean, obviously, that there doesn't need to be specific interventions from a human side. I mean, a provider does need to interpret this information, use their judgment and their training to determine what's the best strategy going forward. All the AI is doing is really providing a foundation based on the data that it receives about what may happen, and allowing the provider to take that next step. The RPM has to be embedded within that population health strategy. You can't just simply let our AI dictate sort of what's going to happen. You need to let AI take the data, and develop a model that shows what could possibly happen as a result of what they're seeing, but allowing the provider and the care management team to make the decision as to what comes next. Next slide. So here are what I guess the key takeaways from this are. I really think it's an essential tool for success in value-based care. You can identify high-risk patients earlier. You can reduce avoidable hospitalization, improve quality, and enhance care coordination. Organizations that really successfully integrate RPM into population health management are going to be the ones that are be best positioned to succeed in alternate payment models. Again, it's not just individually treating the patient and providing really good quality care comprehensively that is coordinated, but it's also really understanding populations and showing what interventions are needed to meet the objectives of the model and to show what that overall ROI return is going to be. Next slide. And that is it for me. So I'm again, thanks very much for the opportunity to talk to you all today. My contact information is below. I know a lot of you on the call already know how to reach me, but if you have any questions, ideas, suggestions, thoughts, please don't hesitate to reach out. Thanks again.
Okay, so thank you, Jason. That was a lot of info, good info. Appreciate what you were laying down, man. Feel free to use the Q&A function to ask questions.
And as we give folks just a few minutes to put questions in the Q&A, I'm just going to bring up our next webinar slide. So we do have our next webinar will be hosted by the Pacific Basin Telehealth Resource Center. That will be on Trust as Infrastructure, the Human Foundation of Sustainable Telehealth Programs. That is going to be on Thursday, July 16th from 11 a.m. to 12 p.m. Pacific time. Registration information is available on the consortium events page. And then we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Let me just check the Q&A one more time in the chat to see if I didn't miss any questions. All right, I did not. If you do have questions, again, we will distribute these slides with Jason's contact information as well as Joe and I. We'll be happy to forward those questions on to Jason. Thank you again to Jason Goldwater for his presentation today, and thank you to the South Central Telehealth Resource Center for hosting today's webinar. Have a great day, everyone. Goodbye.
Thanks so much. Bye-bye.